Great, thanks, Fred. Okay, so this paper is really a kind of amalgamation of lots of different things about surgeons, their feelings, their professional identities, their public reputation, the sort of stereotypes that accompany the profession. And much of this paper is really going to be setting up what the surgical stereotype is, what makes surgeons a funny and unusual, or at least a kind of interesting case for thinking about healthcare professionals and their feelings. And I'm going to set the scene for some, across the sort of second half of the 20th century, looking at some quite recent memoirs written by surgeons before thinking about how this kind of historical setup, this kind of well-established stereotype about surgeons and their feelings have come to bear on their experiences of the pandemic and their sort of narratives of themselves in and amongst all the kind of heady emotional climate of the past sort of 16 to 18 months. So I'll just get started. I'm very grateful for everyone at Exeter having me. I'm really excited to speak to you all. I'm looking forward to your questions and discussion at the end. So usually male and often authoritarian or paternalistic, the stereotypical surgeon is volatile and insistent. He cuts first, asks questions later, and is never in doubt. He is good at hard surgeries, but bad at soft skills like compassion and communication. Academically or technically brilliant, he lacks emotional intelligence. He operates with dispassion, but occasionally his capacity for emotional detachment tips into cruelty. He is almost invariably white and at the very least middle class. This stereotype was crafted in the early 19th century, and despite the various transformations British medicine and healthcare have since undergone, has proven remarkably enduring. Since the early 21st century, surgical memoirs have proliferated. Thick with emotional commentary, these autobiographies integrate accounts of professional and personal life and attest to the effective intensity of modern operative practice. No, the slide should not be changing. Not yet, anyway. Since they describe moments of doubt, failure, and regret, and ruminate on the urgency and uncertainty of surgery. These are, I argue, efforts designed to reconfigure the profession's reputation in the 21st century. For example, the blurb to one of the most famous surgical memoirs, Henry Marsh's Do No Harm, compels the reader to challenge their assumptions of neurosurgery as a, and I quote, precise and exquisite craft practiced by calm and detached surgeons. Since early 2020, public perceptions of healthcare professionals, as well as their inner emotional lives, have acquired new potency. The coronavirus pandemic simultaneously re-emphasized the nation's healthcare workers' heroic status and produced complicated feelings of frustration, shame, and indifference, particularly among surgeons who were either redeployed to coronavirus wards or left with little actual surgery to do. This paper will sketch a brief history of the emotional contours of the surgical stereotype in contemporary Britain, drawing on cultural representations alongside surgeons' own writings about the profession, before turning to these more recent memoirs and the impact of the coronavirus pandemic on the image and identities of surgeon in Britain. By no one is the surgical stereotype in the early years of the NHS better embodied than by Richard Gordon's irascible Sir Lancelot Spratt. Spratt first appeared in Gordon's 1952 novel, Doctor in the House. Gordon was himself an English surgeon and anaesthetist who wrote a long series of comic novels on medical themes. Beginning with Doctor in the House, the books were set in St. Swithin's, a fictional London hospital, and follow the capers and exploits of a young medical student, Simon Sparrow. The film adaptation under the same name was released in 1954 and starred Dirk Bogarde as Sparrow and James Robertson Justice as the fearsome teaching hospital surgeon Spratt, a dictatorial demagogue who strode down hospital corridors with a gaggle of frightened trainees and students hurrying along behind him. Spratt represents the quintessence of three aspects of the surgical stereotype in this period. One, kind of paternalism and authoritarianism. Two, emotional detachment, dispassion, and a kind of professional coolness. And three, a kind of self-confidence, an emphasis on manual skill, and a powerful notion of self-efficacy. Surgery was a specialty of action. I'm now going to talk about each in turn, looking both at cultural representations and surgical textbooks in order to anatomize the mid-century surgeon's professional identity and public image. The stereotype as a paternalistic and authoritarian surgical demagogue is pervasive. In varying extremes, he appeared in film, fiction, and on television, as well as in texts written by surgeons themselves. In one iconic scene of Doctor in the House, Spratt stands at a patient's bedside, firing questions at a group of medical students, one of whom has just examined the hapless and prone sufferer and found a lump. Is it kidney? Is it spleen? Is it liver? Is it dangerous? Barks Spratt, before drawing a long incision line on the patient's abdomen, then turning to the by now highly alarmed patient to say, "Now don't worry, this has nothing whatever to do with you." This is obviously a caricature, but authority over both colleagues and patients was key to the mid-century surgical identity. While they began their careers at the bottom of the hospital's pecking order, right from the outset, surgeons were trained with the assumption that they would eventually reach the top of the institutional hierarchy. They must therefore be self-assured. As one 1950s textbook put it, quote, "He can help both his patients and himself by discussion, explanation, and by imparting an atmosphere of confidence." A degree of paternalism was, according to mid-century surgeons, essential to manage the emotions and health of patients. And nowhere was this paternalism more prominent than in the care of cancer patients. Again, in the 1950s, surgeon Gerald H.C. Ovens suggested that a surgeon might want to, quote, "refer to various conditions without giving away to the patient what he is talking about," and identified cancer as a diagnosis for which the trainee surgeon might like to find synonyms so as not to, quote, "frighten the patient." However, he cautioned against using malignant as one of those synonyms, and I quote, "This word must never be used in front of patients as it always frightens them." He reflected on his own experience. "4 times in my life, I have, under pressure, deliberately told patients they have cancer, and every time I have subsequently regretted it. I will never do so again." Even in cases where patients insisted on being told their diagnosis, however dire, Ovens thought that the surgeon knew better. Quote, "In spite of most people's protestations that, 'I would like to know the truth,' that is not really so. They only ask because they are afraid of the truth." However, one of the more surprising features of surgeons' own writings from this period is how reflective they are about their own power, influence, and authority. Despite Ovens' instruction to keep crucial healthcare information away from patients, surgical textbooks attempted to limit the surgeon's authority over patients and mostly insisted on a more collaborative approach to care and treatment. While he might wield authority and can give, quote, "orders," he should nonetheless demonstrate what they referred to as humility. And surgeons must also not allow his authority to tip over into self-aggrandizement. And he should be careful to only ever act within his means. And he must resist the temptation to show off. While mid-century surgeons were undeniably paternalistic in cases of cancer and other terminal illnesses, those same surgeons also imagined their interactions with patients as a partnership. For example, in his 1946 textbook, Frederick Christopher, where Joseph came from, advocated for a mutual and sustained relationship between doctor and patient. Quote, "It is essential for the surgeon really to know his patient and to give the patient an opportunity in turn to know the surgeon." Ovens said that when practicing surgery, you are dealing with living human beings who think and feel and have minds of their own. It's quite funny to me that they have to remind the readers of this fact. He insisted that in clinical work, and unlike Richard Gordon's Lancelot Spratt, surgeons were not dealing with a case or a specimen, and that they must never allow their scientific interest to obscure the personal relationship between the surgeon and the patient. Surgical practitioners in Richard Gordon's book, at least the ones that seemed to succeed, displayed varying degrees of indifference to the patients they treated. The fictional Gordon's colleague, Bingham, had, quote, "the true surgeon's mentality," for, quote, "it never occurred to him that interesting signs and symptoms were attached to human beings," much like the quote in the textbook before. He gleefully refers to maladies rather than people. Quote, "I've got a couple of septic fingers, a lipoma, and 4 circs lined up for major ops already." He rubbed his hands as if contemplating a good dinner, and seems to feel actual joy at other people's suffering. Quote, "There's a kid with a smashing ductus tooth, murmur as loud as a bus, could hardly take my bally's stethoscope away." This is a general rather than specific interest in the humanity of patients, one shared, at least in Gordon's world, by the whole surgical profession. It's not just Bingham who behaves this way. Gordon's novels were, of course, comedies and played serious subjects for laughs. It is unlikely that he himself, a healthcare professional, believed that real surgeons were as disinterested in their patients as some of his characters might make you believe. But I'd wager that the success of these novels and the ease with which he reaches for such stereotypes suggests that these ideas circulated widely in post-war British thought and chimed with many people's experiences of the profession. Emotional detachment was and remains a key feature of the surgical stereotype, one that permeates both lay and professional discourse. Indeed, the profession has long struggled to achieve an appropriate balance between emotional distance and proximity. In 1899, William Osler gave a valedictory address at the University of Pennsylvania. He advised medical graduates to display imperturbability, which he defined as coolness and presence of mind under all circumstances. Patients so valued calmness amid storm, he warned, that the physician who failed to embody immobility, impassiveness, or phlegm would quickly lose their trust. For Osler, maintaining emotional coolness was a way of upholding authority and professional power. Since Osler, this idea has gathered pace and influence, and researchers have increasingly emphasized how institutions and professions establish and maintain particular affective temperaments. Pioneering work by sociologist Renee Fox noted the historical importance of detached concern in mid-20th century medical training and practice. Fox argued that such a posture served both scientific functions and afforded psychological protections as physicians administered interventions that they were unsure would work. Fox's work was complex, and I'll return to some of its nuances in a minute. And the self-representations of surgeons likewise avoided simplistic models of emotional detachment. Instead, a surgeon must have a natural liking for his fellow man and should be able to respond emotionally to their suffering. One mid-century textbook author wrote, quote, "The last acquired quality of the surgeon, which must be considered, indeed, is often the last to be acquired, is the capacity for sympathetic understanding of his fellow men. The surgeon not infrequently has to be the constant visitor of a dying man." And this, I think, we'll turn to the sort of potency of this statement under the coronavirus pandemic a bit later. He had to express authentic feelings, not just perform a compassionate attitude. Quote, "His bearing and his behavior in these circumstances are important professional attributes. These attributes, although polished by experience and training, must not be false and must, to be effective, spring from a genuine sympathy with mankind." I think this is a really interesting dichotomy here between the difference of looking like you care and actually caring. And the impetus here seems to be that surgeons have to actually care about their patients and actually feel a sense of compassion for them, rather than just be able to adopt a certain kind of affective style of communication. Post-war surgical textbooks reveal that feelings played a key role in surgical practice and identity, even at a moment when the profession was supposedly preoccupied with technical skill, innovation, and progress. This is the supposed sort of golden age of surgery, where great kind of innovations are being made, things like transplant surgery is really gathering a pace. And even at a time when the popular stereotype of emotional dispassion was at its most robust and widespread. You know, it's very interesting to me to read these sorts of words written by surgeons themselves against the kind of cultural representations of practitioners like Doctor in the House, and see how different they are, and also the similarities. In my anatomy of the surgical stereotype, authoritarianism, paternalism, and emotional detachment are perhaps the most crucial organs. But there is another that I think is worth talking about, one that I think proved particularly troubling during the COVID-19 pandemic. And that is the notion that surgery is a practical art, one that requires plenty of hands-on experience, that depends on the cultivation of haptic skill, and a specialty marked by action and activity. Surgeons have a strong sense of self-efficacy. As has probably become clear, in the 1950s and 1960s, surgeons spent plenty of time writing for each other. They used textbooks to wax lyrical about the real or ideal nature of their profession, wrote strident letters to medical journals and the mainstream press about how they were being perceived, and penned articles accounting for the current conditions of surgical work. These various texts might not give us much insight into the inner emotional lives of surgeons, but they do, however, allow historians to investigate how surgeons thought members of their profession ought to feel and behave. They're kind of prescriptive texts. Textbooks were generally written by senior surgeons and designed to be read by practitioners at the outset of their careers. These were places where surgeons went to speak to members of their own community. Authors of these textbooks devoted sections to outlining anatomy, diagnosis, suturing, wound dressings, and aftercare. However, they all also dedicated an opening chapter or preface to the elaboration of the surgical identity and to setting out their vision of ideal surgical behavior. In these prefaces or introductions, they also acknowledge the limited ability of a textbook to teach the practice of surgery or guarantee an appropriate emotional attitude among students or trainees. In his 1953 book, Ovens wrote, quote, "It is not the intention of this book to teach you how to behave towards patients or to expound the doctor-patient relationship. Such things cannot be learned from books." He went on to say, "No book can teach you the art of dealing with a patient, the bedside manner." The pedagogical limitations of the textbook were widely acknowledged, in part because of this belief that surgery was both a science and an art. Surgeons, more so even than other doctors, recognized that surgical practice was just that, a practice, one that could be learned and developed only through observation and apprenticeship. It was a craft, or, quote, "primarily a practical art." Surgeons had to be good with their hands, but not necessarily in a feminine or delicate sense. This was a macho profession where participants had to be willing to get their hands dirty. They didn't watch and wait like their medical colleagues. They did things, they intervened. This acknowledgement of the limitations of written instruction at the beginning of every textbook also explains why these are not ideal sources for the researcher seeking historical experience. They are texts that represent a normative ideal of the post-operative surgeon, not an account of real-life behavior or feelings in the early years of the NHS. Doctor in the House certainly seems outdated, and these mid-century descriptions of the surgical identity are very much of their time. So much has changed in surgery and society since then. But one of the things that I think is remarkable about the surgical stereotype is quite how enduring it has proven. While texts written by surgeons for surgeons present a much more nuanced picture of surgical identity, their public image remained relatively impervious to such complexity. Sir Lancelot Spratt remained the dominant model throughout the second half of the 20th century and arguably into the 21st. This is true both for, I think, public perceptions of the profession, but also from within the community of healthcare professionals. Multiple pieces of research have demonstrated that medical students specifically still have a low opinion of surgeons, and that very old, even crass caricatures continue to inform their perceptions of the profession. In 2014, before undertaking surgical placement, a set of British medical students described surgeons as confident of their abilities, harsh, blunt, authoritative, arrogant, independent, competitive, male, and self-sacrificing. These are all words quoted from the study. In both Britain and North America, applications to surgical specialties since the millennium have seen a significant drop in numbers. In surveys designed to identify why this might be, respondents held uniform stereotypes of surgeons as self-confident and intimidating. Surgery was competitive, masculine, and required sacrifice. To succeed, students felt that they must fit these stereotypes, excluding those unwilling or unable to conform. Consequently, for many people, surgery was neither an attractive nor realistic career option. In other words, negative stereotypes of surgical authoritarianism and rigid hospital hierarchies still deter students from a surgical career. As I suggested earlier, Emotional detachment also remains key to the surgical identity and public image. Over the course of the 20th century, it became evident that detached concern was a historically specific pedagogical and professional stance that would shift in response to social, cultural, and political changes. The growth of biomedical experimentalism, for example, in the 1950s, necessitated both epistemic and emotional forms of distancing. By the 1970s, however, Renee Fox observed that some medical students placed much greater emphasis on feeling with the patient and accepted the necessity for detachment with greater ambivalence. Indeed, in the 21st century, clinical empathy is held up by many as a pedagogical goal and moral virtue. So you hear a lot about the importance within sort of surgical circles about compassion and empathy and a sort of patient-centered model of surgical care. And again, this really sort of sits uncomfortably with those medical students' perceptions of the profession as anything but those things. Fox's model of emotional detachment was therefore complex, nuanced, and changeable, far more so than the caricature of dispassion presented in popular culture or by many surgeons themselves. These more simplistic notions of detached concern or imperturbability, I don't know why I put that word in twice, I could have just got rid of it entirely, continue to predominate in discussions about surgical behaviour and ethics today. While many 21st century surgeons might not seek to become or present themselves as unfeeling, they often see emotional detachment or detached concern as a desirable professional characteristic. As anthropologist Jodie Halpern suggests, doctors often argue that detachment is needed not only for practitioners to avoid burning out, but more importantly, in order to provide objective medical care. This notion remains widespread in the public sphere. A 2017 article in Prospect magazine included this passage. Emotional detachment from the fraught context in which they have to make life and death decisions can result in better choices being made. Being immune to stress might actually benefit patients by facilitating empathy. Too much emotion can lead physicians and other caregivers to turn away from their patients in fear or disgust. A calm analytical logic enables surgeons to reach out their hands to help. Finally, the paradigm of surgical efficacy, of self-efficacy among surgeons also persists into the 21st century. This came up time and time again when interviewing practitioners. They described the things that attracted them to the profession in the first place, was that surgery, unlike medicine, is a practice of doing and fixing. I don't mean to suggest, by the way, that their narrative about surgery is correct or that medical professionals or physicians don't do and fix, but this is how surgeons tend to speak about the difference between surgery and medicine or internal medicine. One surgeon put it thus: the thing I loved about surgery, the thing I still love about surgery, is that people come to you with a problem, which you diagnose and fix. The paradigm of sorting out problems, fixing them, moving on, I really responded to. I thought it was great. In a Royal College of Surgeons podcast, Dame Claire Marks said, as a group of people, we are proactive. Uncertainty, error, and doubt are therefore fundamentally problematic for a surgeon's persona and sense of self. And this came up in a bit of research I did about how surgeons cope with death. And a lot of surgeons think that death is a kind of failure. One surgeon said to me, for me, I became a surgeon to fix people. Plus, I know in myself that I only have a finite amount of emotional energy to go around. So when someone dies, I put them in the box marked, I can't fix you anymore. Then I take a deep breath and try and fix the things I can fix. In her 2009 review of Gabrielle Weston's semi-fictionalized memoir, Direct Red, journalist Elizabeth Day commented on the allure of healthcare. We are all, she said, to varying degrees, fascinated by the practice of medicine because of its curious combination of dispassionate abstraction and extreme human emotion. Since the beginning of the 21st century, surgeons have been increasingly capitalizing on this allure by writing and publishing autobiographical accounts of their careers. These memoirs allow us, or so they insist, insight into the surgeon's mind and into the surgeon's heart. These are emotional autobiographies, less about the technicalities of operations or the mundane day-to-day lives of jobbing healthcare practitioners. They are sometimes philosophical reflections on life, death, and the surgeon's responsibility to navigate a path between. Despite the continuities I've identified here today, the world has, of course, changed since the foundation of the NHS and since the publication of Doctor in the House. Social norms have shifted, the rigid hierarchies that dominate healthcare have flexed slightly, and the power imbalances between doctor and patient have leveled somewhat. We also live in a more emotionally expressive era, one where mental illness is more openly discussed, and where there are new expectations around well-being and its maintenance, particularly in the workplace. There is now a certain degree of cultural pressure to talk about your feelings, acknowledge trauma and distress publicly, and seek help and support when unhappy, anxious, or depressed. This can be seen in the many media campaigns run by mental health charities designed to encourage people to share their experiences of depression and other mental illnesses. The hashtag Time to Talk hashtag is everywhere on Twitter, and public figures like Matt Haig have built their brands around this kind of emotional platitude. Many of these campaigns direct particular attention to men in an attempt to encourage them to overcome their socialized tendencies towards silence and emotional repression, so they see it. Surgery was and remains an overwhelmingly male-dominated profession, and so the intersection between gender and feelings is particularly pertinent. In response to these changing circumstances and cultural norms, and over the course of the past maybe 20 years or so, some surgeons, like Gabrielle Weston, have taken matters into their own hands and attempted to reconfigure their profession's reputation by penning moving, emotionally rich, and seemingly frank memoirs. These texts are often framed by both authors and reviewers as revelatory, brutally honest, and frank descriptions of what hospital life is really like. In his relatively brief review of Henry Marsh's Do No Harm, Ewan Ferguson uses the word honest on 3 separate occasions. Emotional detachment is a fundamental theme to many of these memoirs. As mentioned earlier, the blurb to the genre's most famous member, Henry Marsh's Do No Harm, compels the reader to challenge their assumptions of neurosurgery as a precise and exquisite craft practiced by calm and detached surgeons. I think this is a kind of like fundamental motivation that underpins a lot of these memoirs, an effort to return emotions, sort of at least publicly, to the public perception of what it means to be a healthcare practitioner today. Do No Harm also begins with this quotation from the mid-20th century surgeon René Leriche. Every surgeon carries within himself a small cemetery, where from time to time he goes to pray, a place of bitterness and regret, where he must look for an explanation for his failures. Marsh's book is, in some ways, a steady catalogue of the different tombstones he carries within himself. In the first few pages, he describes the emotional costs of an operation gone wrong. Early the next morning, I lay in bed thinking about the young woman I had operated on the previous week. She had a tumour in her spinal cord, and although I do not know why, since the operation had seemed to proceed uneventfully, she awoke from the operation paralysed down the right side of her body. He wrote about his grief, about the memory of her lying in her hospital bed with a paralysed arm and leg. This operation disrupted the normal narrative arc of surgery and inflected his feelings about the next one he had planned. Quote, I longed for this next operation, the operation on the pineal tumour, to go well, for there to be a happy ending, for everybody to live happily ever after, and so that I could feel peace with myself once again. And again, I think this taps into this idea of self-efficacy, of fixing, of kind of solving problems, moving on to the next one. When that kind of narrative gets disrupted, it is troubling. However, he also acknowledged that he knew that his memory of the woman he had inadvertently paralysed would fade, would become a scar rather than a painful wound. Another case on his, quote, list of disasters, another, quote, headstone in that cemetery. In contrast to the prevailing professional norm of emotional detachment, 21st century autobiographies written by surgeons attempt to position practitioners as emotionally attuned, thoughtful, reflective. They openly discuss the pain involved in caring for patients, the ones who survive as well as the ones that do not. They attempt to cultivate a new image and identity for the contemporary surgeon, one that is not only in touch with their emotions, but with something important and profound to say about the conditions of life and death, the autonomy of individuals, and the responsibilities of the state. However, while surgeon writers insist that these memoirs offer a counterweight to the conventional stereotype, these memoirs, I think, not only reconfirm many aspects of the original caricature, even exploiting them for narrative gain, but they also align with tendency of life writing more generally. In her analysis of 19th century middle-class men and their autobiographies, Donna Loftus argues that these texts are characterized by a particular narrative of improvement that was employed to articulate claims to success and public recognition. For all their claims to honesty, surgeons' memoirs cannot escape their authors' desires to cast themselves and their profession in a positive light and to see these as sort of progressive accounts of surgical lessons learned. Emotions with negative valences, shame, frustration, and anger, are all features of surgical memoirs, but despite the author's claims to honesty and openness, they remain carefully managed. This management is also evident in the tightrope surgeons walk when discussing their emotional investment in and feelings about patients. They feel just enough, but never too much. Indeed, and despite all their best efforts, these memoirs still manage to reflect some elements of a very old surgical caricature. While they are often emotionally rich testaments to the grief and pain associated with surgery, they also repeatedly reconfirm the fundamental truth and value of professional dispassion. Marsh describes the defensive psychological armor he wore throughout his career, and in an interview published in the Financial Times said, "You certainly don't want to be empathetic." His friend and fellow surgeon, Stephen Westerby, similarly insisted on the importance of emotional detachment, and I quote, "When I started heart surgery in 1972, at least 1 in 4 patients would die. So you had to have a specific type of character to be a heart surgeon. You had to be able to put behind you what was happening during the day. If you killed 1 patient or 2 patients, you put it behind you and you came back the next day." Surgeons have long had an ambivalent relationship with emotions. They occasionally acknowledge that feelings are unavoidable, but they frequently see them as a kind of emotional contaminant, something that interferes in the real work of surgery. Many surgeon memoirists are also seduced by their craft's supposedly exceptional status. Marsh reflected, "I thought brain surgery was exquisite, that it represented the highest possible way of both using hand and brain, of combining heart and science." He goes on to discuss how his idea of surgery had shifted over the course of his career. He'd become more realistic, more pragmatic, more nihilistic about what surgeons could offer their patients. Nonetheless, it remains true that surgery and surgeons are held in high regard by the public. Even the most progressive surgeons today are reluctant to relinquish all of that regard and respect. Admittedly, with some irony, Marsh commented on his anxieties about retirement. Quote, "I will become a member of the underclass of patients, as I was before I became a doctor, no longer one of the elect." The surgical identity and the surgical stereotype is marked by contradictions. Simultaneously paternalistic and compassionate, emotionally detached and empathetic, social and profoundly individualistic, elite, esoteric, and plagued by bureaucracy, robust, resilient, but suffering under unique emotional pressures. It is precisely these contradictions, I think, that has made the surgical stereotype so enduring. Rather than just a straightforward sort of Spratt-esque caricature that quickly became outdated as the world changed around it, it was and remains a flexible and mutable category, something capable of adapting to shifting social mores and healthcare priorities. But what happened to surgeons and their sense of self during the COVID-19 pandemic? The intersecting issues of emotional detachment, paternalism, doubt, anxiety, and self-efficacy have been placed under unusual strain these past 18 months, and the pandemic has revealed and exacerbated many of the tensions and inconsistencies of the surgical identity. As part of my work on the Surgery and Emotion Project, I spent 3 years interviewing British surgeons about their emotions, professional identities, and working lives. During 2020, a new question was added to the list. How are you feeling about the novel coronavirus pandemic? And it'd be interesting, most of these interviews were conducted last summer. So it'd be interesting to revisit some of these people, or at least some members of the profession, and see how their feelings about the last 16 to 18 months have actually changed. Some of the people I spoke to were very optimistic about the future. And so I wonder how that optimism has endured. Many of them answered in ways you might expect any healthcare professional to respond, or indeed any person to respond. However, they also had concerns that were specific to the surgical profession. Many surgeons shared the anxieties and grief we all felt and continue to feel. In interviews, they expressed concern for family members' safety, anxieties about their own welfare, and sadness for children and other young people not being able to participate in the rites of passage we've all come to expect, like finishing exams, celebrating birthdays, and graduating university. One of the things I think is quite interesting about asking healthcare professionals about their experiences of COVID-19 is that obviously everybody missed out on kind of key milestones and markers, But there is a sense, I think, amongst medicine and medical professionals that, you know, it's quite ritualistic. And so I think they might feel those sorts of losses in a slightly different way. But that's not the topic of this talk, but interesting to chat about in the Q&A if anyone wants to. Some of the conversations I had with surgeons, understandably, quickly became political. They criticised the state's response, and for many, the current crisis reinforced their belief that the current government has long failed to support the NHS. They directed particular attention towards the lack of PPE and the absence of adequate preparation. One surgeon I spoke to had purchased his own PPE, complete with respirator, because he reckoned his own hospital would be unlikely to provide him with the necessary equipment. And here I think it is important to sort of point out that surgeons occupy a kind of relatively elite position within the healthcare hierarchy, but also a relatively elite position in society writ large. And so compare this surgeon who has, you know, the financial capital or the sort of financial flexibility to make these sorts of big purchases for himself with other members of the hospital workforce who do not have those luxuries, I mean, or necessities, depending on how you see it. I think sometimes surgeons sort of can simultaneously acknowledge their exceptional status while also slightly running roughshod over those subtleties. While this surgeon's anxieties about PPE were likely shared by many healthcare professionals, and many of the practitioners I spoke to acknowledged that the issues they were facing were by no means unique to surgery, and also many of them acknowledged that surgeons did not have it the worst of everybody in the NHS. Surgeons did also face problems peculiar to the profession. Across the country, elective surgery was cancelled, and we will likely be wading through the backlog for some time still. Decision-making changed and the number of operations declined. Hospitals attempted to create more critical care beds and tried to discharge as many surgical patients as possible. These changes prompted a range of emotional responses, and for many surgeons, exposed unresolved and unresolvable tensions in their work and identities. The right clinical decision was not always apparent, and surgeons had to rapidly acclimatise to a new and acute landscape of risk and uncertainty. While many surgeons encounter such quandaries regularly, what counts as elective, what risks are necessary to take, and in what circumstances, you know, who should be operated on, when, what is the priority here, what is important, and what is the time frame. For some surgeons, however, this uncertainty rubbed up against some of these fundamental tenets of the surgical identity. As mentioned earlier, surgeons have what they call a paradigm of sorting out problems. This is a phrase that they use, by the way. They often talk about it in terms of a paradigm, which I think is quite interesting as an aside. I mean, where that language has come from and why it is so pervasive. Self-efficacy is a vital component of the mental training necessary for surgical performance. Uncertainty, therefore, fits uneasily into a surgeon's personal professional narrative. I also think it's important to recognize as well that while reading surgical memoirs gives a sort of sense that surgeons are really preoccupied, that all surgeons are really preoccupied by these big sort of fundamental ethical questions or moral questions about, you know, what to do, who to operate on and when. I'm not sure whether that is reflective of the majority, and most of the surgeons I've interviewed are not these famous memoirists, but are kind of rank and file practitioners, you know, the sort of ordinary surgeon. And for them, the coronavirus pandemic was one of the first times that they'd really had to kind of engage with these issues on a mass scale and under kind of extreme pressure, and both the pressure from their hospitals, but also pressure from sort of the public, on the public perception of how the NHS was going to function. For some surgeons, this professional paradigm proved particularly challenging because they felt peculiarly underprepared to participate in the NHS's pandemic response, unlike their medical or nursing colleagues, for example. For those surgeons who were redeployed to support non-surgical roles, or in the words of the Royal College of Surgeons of England, to extend temporarily the scope of their practice beyond the normal range of their expertise. 2020 was a time of particular anxiety and frustration. And by this, I mean that there were many surgeons who were put in roles that they were not accustomed to. And that meant either having to do things that were not part of their normal day-to-day work, not part of their normal skill set, or to do things that many of them felt were kind of beneath their sort of their expertise level or their experience level. So you have a lot of cases of surgeons effectively doing nursing work or portering work, and you know, key and fundamental and, you know, a professional skill set in its own right. But for surgeons, they felt like this was a kind of step down, and there was lots of sort of troubled feelings about that sort of shift in status. Not a kind of comparison I share, but I think it's worth pointing out that this is how they narrated some of these changes. Retired surgeons, some of whom also returned to work, were of course particularly worried about their safety, and even as they committed fully to this returned role. The emotions of retired surgeons who didn't return to hospital were, however, also complex. Some missed clinical practice and wished that they could be returning to help in whatever way they could. So sort of feeling of like you're not doing enough, or kind of missing out on the action if you want to be a little less generous about it. For others, the pandemic and the NHS's response has prompted them to reevaluate their careers and recollections of their time in hospitals. And by this, I mean that COVID, even if you weren't on the front line of healthcare, or if you weren't actually involved in providing surgical care or medical care at the time, COVID still prompted a kind of set of emotional reflections, or a kind of thinking through about what their careers had meant to them, the meaning and value of their labor. Nostalgia was a regular feature of my interviews with retired and senior surgeons. Indeed, I think it's a kind of sort of occupational hazard of working in the NHS. Many practitioners lamented the changing nature of healthcare work. They argued that new policies and managerial practices introduced over the last 2 decades had eroded the sense of community and camaraderie that marked their earlier experiences of surgical training. While we all might be nostalgic for a time before COVID-19, the pandemic seemed to have offered these same retired surgeons an altered perspective on surgical work and on their own careers. One retired urology consultant I spoke to said, "I suspect that when this all blows over, there will be 2 generations of doctor. There's before COVID and those post-COVID. The impact of attitudes towards moral versus contractual duty, sharing and coping with fear and uncertainty and regret, and maintaining work-life balance will be enormous and beyond anything that my generation of baby boomers has ever had to face up to. The musing of retired doctors about a relatively trouble-free time will become rather superfluous." While I, as a historian, will never think the musings of retired doctors superfluous, they are my source material, he is right to recognise the altered emotional landscape surgeons are now working in, and is, I think, right to acknowledge that COVID-19 will change many things, not least how healthcare professionals feel about their work, the government and the NHS. And we're seeing some sort of evidence for this in survey data from the BMA that suggests that up to a fifth of doctors are considering leaving their profession post-COVID-19. For one, and here I'm going to conclude, the pandemic has shifted the conversation about what even constitutes a negative emotion about one's own work, reconfigured, or at least began to reconfigure, the notion of vocation, and prompted people, both within healthcare and without, to ask new questions about what we can demand of our employers, even if that employer is the beloved NHS. And by this, I mean, I think COVID-19 has carved out a bit more space in the public arena for negative commentary on working for the healthcare service, and while simultaneously narrowing the scope for the kinds of emotions that healthcare professionals can reflect about on their patients. And here I will end, and I'm really looking forward to your questions and some discussion, and I hope that in that discussion we can kind of bring some of these threads together. Thank you very much.
Thank you so much, Agnes, for just an absolutely fantastically rich and detailed paper. There is, yes, as I can see, that there's the clap function on the reactions if you'd like to use it. But yeah, thank you so much. I think we'll start with questions now. You can either put your hand up in the kind of sidebar, and I'll see you and call on you if you'd like to turn your camera on, of course not compulsory, and speak a question, or alternatively you can put it in the chat and I'll read it out, whichever works best for you. Would anyone like to start? I think I will then. The obligatory chairs question while everyone else thinks of something. You touched on it really briefly, but I'd love to hear more about how that kind of detachment and distance was kind of constructed, I suppose, kind of mid-late 20th century in kind of response and opposition to things like burnout and compassion fatigue. I'm just kind of like, I take that point about it being a kind of a way of avoiding burnout, but I know that it's a lot more complicated than that. And yeah, I'd really like to hear you talk a bit more about that, if that's okay.
Yeah, absolutely. I mean, I think the kind of when Fox talks about this sort of more like kind of caveated detachment, that there is a sort of place for kind of clinical empathy, and this sort of debate really emerges in the like kind of mid to late 20th century. It's still kind of very much a caveated one for precisely that reason, right? That like this is partly about protecting against compassion fatigue, about that giving too much of yourself, can have these detrimental consequences for you as a practitioner. And you really see these sorts of like, I suppose, like this sort of like balance sheet approach, I suppose, to emotions, these kind of medicalized models of emotions emerging after the period that I'm really talking about here. Because in the 1950s and early 60s, really what people talk about when they talk about surgeons' own feelings is they term it morale, right? And it's not the same as the burnout, the compassion fatigue, the stress, the strain that then becomes sort of more powerfully articulated later in the century. It's really a sense of like, what, and it's more about working conditions in a sort of strange way, right? That it's more about things like, whether you have good colleagues or a positive environment in your hospital, or that you have a nice doctor's mess, or you have a lot of great hospital dances or whatever. And this kind of like idea that emotions are risk factors almost, that they are things that you can kind of quantify and identify as potential threats to emotional well-being or to emotional health, is very much a kind of part of that like 1970s, 1980s moment. And then I think comes back now. And this is still the way people sort of see it, right? Is that like, and I kind of alluded to this, is like you need to have some emotion, but not too much. And I also think that you see a slight decline in this idea, this distinction between authentic and performed emotions. So more recently, in the like late 20th century and into the 21st, you have this idea that you can teach compassion, or that you can teach like an empathetic performance. And when medical students are training and doing things like kind of OSCEs, they have a kind of literal checklist of things they have to perform in order to display a kind of emotional commitment to their patients or display compassion. And the idea that there needs to be sort of like a deep, authentic feeling between doctor and patient, I think is now seen as more of a risk to things like burnout and compassion fatigue, rather than something that is like a fundamental element of what it means to be a surgeon in the kind of, in the modern age. I don't feel like I really answered that properly, but
yeah, no, thank you. That helps a lot. Thank you very much. Okay, we have a couple of questions. So I'll read these out if that's okay. So this is from Diane Orban. What do you think will change post-COVID? Surgeons' identity and willingness to show emotion. Surgeons' identity and willingness to show emotion, especially as it relates to empathy, compassion, and shame.
Yeah, it's a great question, and I wish I knew the answer to it. I suppose like historians, I'm a terrible historian for like making predictions, which is like absolutely not actually my professional skill set. But I do think that it won't make the difference that I think some people think it will. Partly because, as I mentioned, particularly for surgeons, and this might be different for other healthcare professionals, but surgeons' role within the pandemic was particularly, it was different, right? Because they're either continuing with their work and treating non-COVID patients, right? People who still require emergency surgeries, in which case their interactions with their patients, although different in terms of like, this social distancing and mask wearing, all those kinds of stuff have obviously changed the interaction between all doctors and all patients, regardless of whether they're on COVID wards. It still retains an element of the kind of pre-COVID life, right? They're still conducting the same sort of surgical intervention, the same sort of clinical intervention. And then on the other hand, you have them occupying these sorts of different sort of tenuous roles on the COVID ward or in intensive care units or whatever, where they're not really there for their professional expertise. They're there serving a slightly different function. And I think one of the things that will change just generally is that I think there is more public appetite for, so I've been looking at these sorts of questions about like healthcare professional emotional well-being and emotional health and psychological sort of safety and all this kind of stuff for a while. And it was definitely a topic of discussion before the COVID-19 pandemic. I think it's a big part of the sort of surgical discourse for much of the last 10 years. But I do think that the pandemic has catapulted that, perhaps slightly insular professional debate into the public realm. I do think there is a lot more public discourse generally about the emotional well-being of healthcare professionals, including surgeons, including physicians, including nurses, and to a lesser extent, I think, other members of the hospital workforce. And whether that has an impact on actual professional practice, I think I'm slightly more skeptical on, right? You have a lot of sort of public declarations of how awful it is, working in these conditions, and how awful it is seeing so many people die on such a, mass scale, which obviously it absolutely was. And I don't think you need have much of an imaginative leap as to be a sort of member of the public and to sort of see that. But I think based partly on what interventions I've already seen the government proposing about things like emotional vulnerability and emotional safety in healthcare settings, I'm a bit skeptical that there's going to be any kind of radical change. So, things like a lot of money is being put into well-being workshops, or, a lot of the money that was raised, say through Captain Tom or whatever, is being put into these sorts of resiliency training or whatever. And these sorts of interventions, I'm slightly more skeptical, are going to be the kind of things that are really going to make a big difference to people's emotional experiences of their work. And I think, really what COVID has exposed is the pre-existing structural problems of the healthcare service and what it's like to work in the healthcare service. Things really basic things in some ways, staffing, rotas, annual leave, workload, paperwork, all these things that people have been complaining about for a long time. I think COVID has exacerbated and exposed those issues, but I don't think there's necessarily going to be the kinds of interventions in response that are going to make a big difference to that kind of world. And so to come back from my tangent, I suppose my answer to this is, I think there is going to be a kind of greater public acceptance of healthcare professional emotions and expressing those emotions, but I don't know whether that's going to actually translate to any, real change for the people who are working in hospitals, if that makes sense. That's my big political pronouncement, I suppose.
Thank you.
Yeah, no, thank you. Okay, we have another one from Giskin or Giskin Day, sorry, who says, thank you for the interesting talk. Thank you for the interesting talk. I was wondering about your positionality in your research. What impact have your own emotions played in the way you have framed your mode of inquiry and findings?
It's a great question. And it's two slightly different answers, one for kind of pre-COVID and one for kind of COVID. So pre-COVID, I thought a lot about my relationship with the surgeons I've interviewed, and how my particular kind of position in society and in academia altered the kinds of interactions we had. So I think that I'm not a healthcare professional, I'm a historian with no medical background. And that is both very useful in the kinds of work I was doing and also problematic, right? So it's really useful because it means that surgeons, I think, the surgeons I interviewed often felt more at ease in being candid or critical about their professional communities or their professional associations or societies or the institutions they worked in, because I was outside of that world, and my work or me had no influence on their career progression. And surgery remains as a kind of profession as a whole, very hierarchical, very dependent on the power and influence of bodies like the Royal College of Surgeons, for instance. And so being able to speak to someone who was outside of that world, I think was really productive. I also think it was difficult because I often had to translate what exactly my work was to a sort of more surgically minded person or a more scientifically minded person. So a lot of people thought, as a kind of oral historian, I don't come at these sorts of conversations with hypotheses or, I'm not doing kind of thematic analysis of my work. It's qualitative, but it's also historical. So it's kind of it's extra qualitative. And I think surgeons who had come into contact with qualitative research before had mostly encountered social science research, which does have different norms and kind of assumptions behind it. And so often I had to sort of translate what the point of what I was doing to surgeons and sort of learn a kind of different language, a different research language, different kind of research, and have a sort of different kind of conversation with professionals. I also think that my gender and age play quite a big role. So pretty much everyone, most of the people I interviewed were men, because that reflects the gender makeup of the profession, but also most of them were a lot older than me. And so I did quite a bit of shadowing surgeons, and I was often slotted, I think, kind of unconsciously into the category of medical student, which was, it's an interesting thing to kind of observe happen, but also meant I was sometimes asked to do like menial clinical tasks, which I obviously was not in any way qualified for. And so that was an interesting dynamic that I think kind of played into a little bit into how like lots of surgeons spoke to me. And not, I don't mean this is necessarily negative, but it just isn't, something worthy of note. I think also it's an interesting experience being effectively a patient, right? Like I am a patient talking to a practitioner, and that is the role that I occupy in their kind of like imagining of the world, right? When Henry Marsh talks about him being member of the elect, I think, he's kind of joking, right? He's not being really serious about that. But I do think a lot of surgeons see this quite big gulf between people who are in and people who are out. In terms of during COVID, I think one of the things that kind of struck me, I think, in terms of like my own sort of emotional stance or whatever, is that, I think being out of the profession gave me a little bit more of a sense of perspective on how, lots of different workplaces were responding to the crisis, or lots of people in different kind of professions were having incredibly intense and traumatic experiences of the pandemic. And I think, there is, and this is true, obviously, for any profession, it's not unique to medical, but then, there's a sense of sort of slight myopia that you think that your experience of the health of the pandemic is, the worst, or is the most all-consuming. And I think being out of that gave me a little bit more of an ability to think about, there are obviously real pressures and challenges and awful things that surgeons had to encounter and experience during the pandemic, but they were also able to encounter those experiences with quite a high degree of kind of social and financial privilege, even within, the healthcare workforce, as I mentioned before. And so I think that was quite an interesting kind of tension, I suppose, between what I was doing and the people I was speaking to. I mean, there's so much more I could say about my own feelings on this, but I'll leave it there.
Perfect, thank you. Does anyone else want to come in? Arthur, please, yeah.
Hi, Agnes. Thank you very much, and sorry for being bumped off the call earlier. So unfortunately I missed the opening, and you may have covered this in that opening. So apologies if this comes, it gets you to repeat things that you've already said. I suppose I've got two kind of questions. One from obviously the side of thinking about shame, and the other from thinking about, as a literary scholar, and also as a fan of your article that just for a plug that you just released on Mills and Boon, which is great. I heartily recommend it to everyone to rethink your opinions on what Mills and Boon is actually doing. What I suppose, to try and blend these two questions together, on the one hand, I'm kind of interested in how, in the formation of the stereotype, the surgeon stereotype, what role internal medicine plays as the foil to that. Obviously, there's a sense in which there's always been these kinds of antagonisms between surgery and internal medicine in doctor memoir, doctor narrative, right up to, but obviously maybe one of the most sort of striking kind of depictions in the last sort of 20, 30 years is Scrubs, where of course it relies very much on a dynamic between a surgeon, the kind of, I guess, the next iteration of the detached surgeon is the knife jockey surgeon, right? And that's very much the stereotype that they play on there. And I was just wondering how, when you were thinking about the work that you were doing with the surgical stereotype, how you dealt with the foil of the physician as the kind of counterpoint to that. And I guess part of my wondering, and this is to kind of maybe push you to talk a little bit more openly about shame, although you glancingly referred to it several times during the course of your talk, is if we understand shame is not just about negative self-conscious emotion, but also about the desire to avoid shame as being a kind of critical part of what we understand as the broader shame process, to what extent is the kind of investment in the stereotype also about warding off potential shame in the future, and also and in that relationship then, to bring it back to my previous part of the question, to what extent does the foil of the physician also act as a way of avoiding shame, if that makes any sense? And sorry for getting you to repeat things that you've already said.
No, that's a really great question. Thank you. So I think when surgeons talk about physicians, they adopt one of two styles, I would say, generally speaking, that are kind of both the same, but they just take a slightly different tacks depending on, you know, what kind of, I suppose, impression they want to give, or what kind of person they think they are, I suppose. So one is they think that they are superior, that the surgery is the sort of superior medical craft, that it is the thing that's the top of the pecking order, and that they actually do things, whereas all these physicians, they just, like, you know, tinker with pharmaceuticals and don't ever actually get anything done, and it's all about, you know, kind of chatting and thinking, and, you know, it's not an efficacious practice, right? And which is, I think, goes back to this idea that surgeons, this very powerful notion of surgeons is like, they are the people who get things done, they do stuff. And, you know, you often hear about, when surgeons talk about their kind of career paths, and they always will obviously spend some time doing medicine, they'll always talk about how bored they were, like, oh, it was, you know, so dull not being able to do anything, you know, the implication being that the physicians don't do anything, which obviously isn't true. And so they either say that, or they say, oh, we're just the mechanics, right? That we're not, you know, we don't actually, you know, they're the people with, like, the highfalutin ideas about physiology, and they're the ones who really understand the body, and they're the ones who really know stuff. We're just the, you know, the butchers, the barbers, the kind of tinkers underneath the hood, as it were, which is effectively the same dichotomy, right? But it's just a different sort of spin on exactly how you're framing it. And I think one of the things, I think your point about, I mean, I think this is also where shame comes in, right? Is that narrative about themselves and about medicine is sort of thrown into question by the pandemic, because in the pandemic, surgeons were the useless ones and physicians were the ones who actually could do something. And again, that's a bit of a caricature, and also slightly problematized by the fact that, you know, especially in the early days, physicians were also not in a great position to, you know, it's very difficult to, once someone's in hospital on a ventilator, you know, really it is a case of kind of watch and wait. You know, there's not much sort of active intervention that can be done at that stage. But nonetheless, I think a lot of surgeons felt, you know, inept, kind of futile, superfluous to demand, which is really difficult if your whole self-identity is, whether you're sort of spinning it positively or negatively, is that you are an active intervener in people's bodies and in people's lives, and that you resolve problems quickly and efficiently. And so, you know, that I think is why, one of the reasons why so many surgeons found this past, you know, 18 months or whatever incredibly challenging, not just on a kind of practical day-to-day level, but also for, like, their sort of psyche, sense of self. But I think the point you make about, like, shame and the surgical stereotype to in a similar way as being a kind of protective mechanism, I think is absolutely true. And I think that's one of the reasons why the stereotype has endured so well, right? It's because it wouldn't have lasted if it didn't work for surgeons in some way, right? Because the Sir Lancelot Spratt stereotype is not necessarily a very flattering caricature, right? It doesn't necessarily show surgeons in a very positive light. Mills and Boon, on the other hand, I think actually is much more positive in terms of, like, the perceptions of surgery it cultivates. And in this book I'm writing, I have a bit where I talk about how surgeons and medical journals and in their own journals write about cultural representations in the 50s and 60s, and how they perceive the different ways that they are represented. And they're very critical of things like Emergency Ward 10, which was a soap opera, because they saw that as sort of sentimental and sort of silly and feminine, basically. But they were actually very complimentary about Richard Gordon's book series and about the films. They thought that this was sort of funny Rabelaisian humor, that this was a kind of, macho, gutsy kind of narrative of themselves. So even if it's not particularly like flattering, they still kind of like it. And I think that's something that has sort of persisted, even if it's sort of slightly lessened in its kind of extreme sense, is that, if you have this narrative of yourself or of your profession as, interventionist, active, provocative, emotionally detached and disinterested, then you can use that as a barrier between, between like what you project to the world and how you really feel about your patients, and the kind of actual like emotional, psychological risks you expose yourself to. And I think, shame is a huge part of that, right? Is that like, if you don't have to think about, if you can kind of model a version of yourself which is like impervious to feelings, then you are also impervious to the like feelings that have these sorts of negative valences. And if you don't feel, maybe you'll lose out because you don't feel great feeling and intense joy about your patients, but you also don't lose out because you don't have the flip side, the kind of counterweight to those sorts of like the consequences of dealing with patients and having a tough time with it. Does that answer your question in any way? I don't
know. Can I draw something out from that, which I think you've half answered already? I'm really interested because I think you've done a really lovely job of talking about like the construction of this kind of stereotype, but then kind of like talking about the nuances and contestation within it as well. But like, is there a kind of a I'm sorry, I can't quite think of how to phrase this. Is there such a thing as being too close to the ideal? Is there like an extent to which surgeons can become too detached or, too kind of invested in this in a way that then actually kind of like provokes some kind of concern or kind of not quite pathologization, but like, is there a kind of a limitation in terms of how far that kind of caricature can take people?
I mean, several things in that. So one, I think one of the problems with my research, right, is that most of the people I've spoken to who have volunteered their time for me and who have wanted to be interviewed by me are people who think of themselves as emotionally literate. So whether those conversations actually reveal that to be the case or not is a different question. But, the kind of, I know from talking to, I think from talking to surgeons working today that these sprat stereotypes do still exist, that they stalk the wards, and that a lot of those medical student experiences or perceptions that I talked about, it's partly about like cultural representations, it's partly about their actual experience in surgical placements. And so, bullying, intense like disinterest, sort of like banter, like very like lad culture, is absolutely still part of the surgical experience and surgical identity today. It's just, it doesn't always make its way through to the kind of research that I do or to the kind of public perceptions, because those public perceptions are written by people like Henry Marsh, who are really invested in this alternative portrayal of the surgical identity. The person who I think shaped it is the sort of most interesting example in some ways is Stephen Westerby, who, for those who don't know, is a cardiothoracic surgeon and wrote a memoir called Fragile Lines. And he is a self-defined psychopath. So he says that he had a frontal lobe injury as a student and then is now has psychopathic tendencies. And he says that most surgeons are psychopaths. And so there's this sort of funny, which lots of surgeons disagree with, and I personally don't think it's true. But he's really kind of owned this like really extreme stereotype. And in his book, although he writes a lot about patient suffering and patient death, he does write about it with like high characteristic dispassion. Talks in the quote I think I gave in the paper, he talks about killing patients, which is effectively what's happened, but it's very sort of a dismissive and flippant way of talking about people's lives who are under your care. And he he sort of owns that like pathologization of the surgical stereotype. But I will say that although he is a very prominent surgeon and has published this very well-received best-selling book or whatever, he lost his job and was no longer for various complicated reasons, not just because he's a psychopath, but I'm sure that played a role. And he was famously very difficult to work with and no longer works as a surgeon in the NHS. And I do think you see some of that sometimes emerging. So the other case of this is at St George's Hospital. The cardiothoracic team there came under a lot of scrutiny because they were a surgeon on the team was sent the severed heads of dolls in the post, and or like a rabbit's head or something. There's some sort of awful, these really intense moments of like bullying and undermining. Really hierarchical and sort of quasi-psychopathic behavior, as Westerby would put it. Like that, I think is, it does have its consequences. It's just that those consequences, I think, are perhaps slightly less frequent or pronounced as you would maybe like.
Yeah. Okay, thank you. Really, really lovely to see a question in the chat from Natasha Feiner. Hi, Natasha. I hope you're well. So Natasha says, thanks for a fantastic talk, Agnes. I absolutely agree with your take on the ways that COVID has exposed and amplified pre-existing issues, such as workload and working practices. Unfortunately, I'll have to hop off shortly, so we'll save a proper question for another time. But I'm just thinking aloud about the gender dynamics at play here, especially in specialties that remain largely male-dominated. So do female surgeons need to perform and feel emotion differently?
Great question. And I tried to sort of allude to the gender dynamics in the talk, obviously didn't have enough space to talk about them really fully, but absolutely, I think. So I did interview female surgeons, and there is the Gabrielle Weston memoir is written by a woman. It is, I think, quite interestingly, one of the only famous sort of recent surgical memoirs written by a woman, which I think says something about what kind of emotional latitude is allowed for male versus female practitioners, that, that male surgeons have a bit more space to be kind of countercultural or vulnerable or expose their inner working lives in a way that female surgeons, and Gabrielle Weston got a lot of flack for her memoir, and also kind of left the NHS quite soon after publishing it. She still, I think, does some part-time locum work, but she really kind of shifted career trajectories into more like public-facing media stuff. And when I've spoken to female surgeons about their kind of experiences of emotions, their expression of emotions, what kind of identities they have to adopt, a very common response is that the women who succeed in surgery have to conform to have to kind of overplay the emotional detachment that is required of their male colleagues or is expected of their male colleagues. So you get a lot of kind of quite critical commentary on women who have, really like are the sort of adhere to the kind of worst elements of the stereotype in order to succeed. And there's a lot about kind of, not being supportive of other women in the profession, or kind of, pulling the ladder up behind them. This sort of language is obviously not specific to surgery. Lots of conversations about like professional women in different kind of high intensity, industries follow a very similar pattern, that, the few women that do make it to the top are, accused of, or are, being particularly disinterested in the, of being kind of unfemale in some way, or like abnegating that kind of more like stereotypically female side of them. I always want to be a bit skeptical of those sorts of narratives, because they are often themselves driven by misogyny. And so, I don't want to buy into those wholesale, but I also think there is truth to the fact that you do have to, the stakes are high if you want to succeed as a woman in surgery. So at the moment, it's about 13% of surgical consultants in the UK are women, and in some specialties that's much lower, and some it's a bit higher. And so women are still underrepresented in the profession, and I think it remains an incredibly difficult profession to break into. The pace of change has been slow, and I think some of that is down to things like parental leave and structural issues. I do think a lot of it is still cultural, that there is still a kind of assumption that surgery is for men, and that the kind of people who succeed in surgery adhere to these stereotypes, which are themselves coded masculine. And this is also an overwhelmingly white profession that really does kind of favor a kind of white public school boy sort of culture and kind of community, the old boys club, that kind of thing. And so that, that has implications for all sorts of things like gender, race, class, etc. And so I would say that female surgeons have to navigate that landscape incredibly carefully. I do think that there are female surgeons who really lent into a more emotional style of work, particularly in specialties like breast surgery and pediatrics, which tend to be more female dominated, not dominated, but have a better representation of women in them. And so I'd say, I mean, in some ways, it's a story that is told about all sorts of workplace settings, right? This is in some ways not unique to surgery, and in other ways, I think is exacerbated by surgery. And going back to some of the stuff before about like, what are the consequences for people who really behave badly in surgery, like the people who are the sort of quote unquote psychopaths that aren't actually psychopaths, but think they are. The consequences for those people are few and far between, partly because of the way surgery is structured and the way that healthcare in general is structured in terms of like the person who is, who is your line manager. This is sort of in some ways quite dull, but like, who is your line manager in a hospital, right? Like, who is responsible for, what is the HR system like? What are the sanctions for people who cross, a serious boundary? And I think in lots of cases, there are no sanctions for people. And so, I've heard very awful stories of like sexual harassment and like really gendered language and critique, and and also very kind of banal and kind of sort of, I think what people see as very uncontroversial statements about like women's reproductive capacity or intentions, or kind of innate biological skill sets that go completely unchallenged. So I think it's a tough old world out there, and I wouldn't want to be a surgeon, but I admire the women who manage it.
I now have maybe a bit of an evil question with my my bridge from your last answer being that I once had to sit through close to an hour of some guy arguing that the role of the medical humanities was to feminize medicine. A big part of me died that day. But what do you see as being the role of the history of medicine specifically in some of the conversations that you're talking about going forward, and what can history do here that no one else can?
So it is an evil question. Luckily, I have thought before, so I can draw on some previous musings that I've had. I think one of the things that my history at least can offer is I think that a lot of efforts in surgery today that are designed to do things like diversify the profession or alter the kind of cultures and sort of standards of behavior are very sort of, well, quite or very, depending on your perspective, narrow in focus and quite surface level about what they think appropriate solutions could look like. So when they do things like, a lot of it is that, surgeons are very susceptible to that kind of lean in feminism of like, well, we just need, more female role models, or we need more surgeon, we need, to give women special days off on International Women's Day or whatever, these sorts of very kind of, I think, neoliberal, can I say that? I don't know, models of what like diversification should look like. Yeah. And I think that at least, and also there is a lot of focus, I think perhaps more focus than there ought to be in terms of like what that means then is disregarded, but on things like parental leave, like on the sort of, there's a lot of focus on, which I think are absolutely huge issues in surgery. Like I'm not denying that these things are incredibly important, but I think there is this sort of, the kind of cultural history side of what I do, I think is important here because it shows quite how deeply embedded some of these assumptions about what surgery is, what a surgeon looks like, how a surgeon should behave. And I think the history of surgery shows that these are, profoundly, these are fundamental issues. These are constitutive elements of the surgical identity. They're not kind of embellishments that can be like easily swept away. They are what makes surgery surgery. And I think that perhaps one of the things that I would push current policymakers or practitioners to think about is that, what might you have to relinquish as a surgeon in order to make the achievements that you think need to be made? Because I think as I sort of said before, one of the things about the surgical stereotype is that it only works because it works. Like it only still is around because it serves people. And so it's not possible to retain something like, an appropriate degree of deference from your patients and also, achieve a kind of flattened hierarchy in the profession, right? You might need to lose some of the things that you think are valuable in order to gain the other things that you purport to care about. You know, and I think that this is true too, you know, when people talk about like, you know, meritocracy, right? Or like one of the other issues that comes up a lot with like female surgeons is about that less than full-time working, for example, is inadequate because you need total absorption in the profession and in the hospital and in the operating theatre in order to be any good. And there's lots of evidence that suggests that that's just not true, that less than full-time training, you know, results in equally, if not more, competent surgeons. But there are powerful myths around, you know, total commitment, total abnegation of the self, and that's the only way to be a good surgeon is to, you know, deny your personal life or to have anything beyond the hospital. And that's obviously a profoundly exclusionary model of surgical professionalism, and is also not necessary, I think. And so I think that's one of the things that, like, you know, history can indicate here, is that the sort of imbrication of these different aspects and how you need to maybe have a more radical rethink of what the surgeon is in order to get anywhere. You know, we're not going to get a more diverse profession by having like women in surgery groups, right? Like, they may be nice places to be, but they're not the things that are going to fundamentally alter what it's like to be a woman in the profession. Is that helpful? I mean, I agree with you, by the way. Yeah. The medical humanities are not there to feminize. I mean, this is one of the things that I find so frustrating. Sorry, I'll stop in a second.
No, go on.
One of the frustrating things I find with some surgeons and other healthcare professionals when I talk to them about what I do is they see as a kind of like an embellishment, like it's something that like history is something they can use to teach them humanity, or a sort of sense of like compassion or empathy for like the human condition. When I'm like, no, I'm here to be critical of you, not here to bolster your, you know, sort of your liberal humanist education. You know, I think that's something that comes up a lot.
Very, very, very well put. No, thank you very much. I should just note for everyone's benefit, if you haven't seen in the chat, Arthur has been kind enough to post Agnes's fantastic article, so do please have a look. Would anybody else? I think we have just about time for one final question, if anyone else wants to come in. But otherwise, I'll let you go very slightly early. Okay, if we could just say another quick virtual thank you to Agnes, yeah, thank you so much for a really, really fantastic talk and answers to you, and thank you to everyone for coming along and for coming up with such great questions. So our next talk is on the 2nd of September, which will be on the same time, I think, and that is Professor Laura Bear and Nikita Simpson from LSE. And their talk is titled Building Cooperation, New Relations of Stigma and Mutuality in the UK's COVID-19 Recovery. And you can kind of register and find out more about it in the same place that you found out about Agnes's talk. So unless there's anything else, yeah, a big thank you to everyone. And yeah, especially you, Agnes, because that was absolutely fantastic. So thank you.
Thanks. My pleasure. Thanks for having me.
Bye, everyone. Take care. Bye.